Good afternoon. Welcome everybody to today's Break for Health session. Today we're going to talk about reproductive and sexual wellness for a lifetime of good health. And I'm so pleased that you've joined us today. We have a fantastic group of panelists. And of course, we will be led through our conversation today by our moderator, Nettie Carter-Smith, who's the Director of Community Relations at Rocking Horse Community Health Center. We're supported on the back end with technology by Alex Miller from Shiftology. And I'm Joan Elder, the Program Coordinator for Community Health Foundation, and I'm so pleased to be able to present this session to the public. So I want to give you a couple of tips for watching this session. If you move your cursor to the bottom of your video screen, you'll see some boxes that you might not see in a regular webinar session. So there is the chat box, and you'll have the ability to view chat messages, but not to enter any. So there's also a Q&A box where you can ask questions to panelists, and they'll be answered in that box. If there's information the panelists want to send out to everybody, that will probably show up in the chat box. And lastly, today's session is being recorded, and we also have live transcript turned on. And if that is bothering you or is annoying to you at all, feel free to click on that live transcript box, and you'll have an option to hide the subtitles. So I am thrilled to turn this conversation over to Nettie Carter-Smith, and we will be starting off with a couple of poll questions that we'll invite all of you in the audience and every one of our panelists to take part in this question. So Nettie, why don't you go ahead and start us off, and we can go ahead and start filling in our answers here.
Okay, great. Happy New Year, everyone, from the Break for Health session 2022. This is our first session. We're excited. We're back. We've got a great topic today, and it's Wednesday and it's hump day. So let's take a couple more seconds and answer these poll questions. And then I will give the panelists an opportunity to introduce themselves, and they'll also answer a poll question. Okay, let's take a look at the answers right now. See what we've got. March is the month when we celebrate which of the following. You've got a couple different options. I know Joan's going to give us the answer for that, but let's see the results.
There we go.
That's it. Okay, looks like 59% said that it's endometriosis month.
Well, guess what, Nettie?
What?
Everybody got it right. This is actually recognized as all of those things.
Yeah.
The month of March.
Yes.
So congratulations, everybody.
Congrats. So let's take a look at question number 2, which actually talks about our topic. Where did you learn about sexual health and reproduction? Wow, that's interesting. We're probably going to talk about that. 48%, ding, 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 at school. And then family or parents was 44%. 22% was other. I'd like to hear what the other was. We'll just leave that right there. How about that? So let's introduce our panelists. And I would be remiss if I did not say this. Salt and Pepper is here. Let's talk about sex, baby. Let's talk about sex. Introducing, we have up first, Brittany Bruce. Brittany.
Hi, everybody. My name is Brittany Bruce. I'm the HIV coordinator and supervisor over sexual health and wellness in Clark and Montgomery counties here at the Clark County Combined Health District.
What about poll question 2?
What my answer was?
Yes, ma'am.
I learned about sexual health from my parents.
Okay, great. Danielle.
I am Danielle Rains. I am a labor and delivery nurse at Springfield Regional Medical Center. I am currently teaching all the childbirth education classes along with another nurse on the floor, Shanice. And I am taking on some other things in the education world at Springfield. And the poll question, I did learn from my mother. She was always very open about discussion about sexual health at home. So
That's good. Good. Sarah.
Hi, everyone. My name is Sarah Dalston. My pronouns are she, her, and I'm the Director of Education at Planned Parenthood Southwest Ohio. I oversee all internal and external education and training services and programs that we run, which includes everything from relationship and sexual health education for youth, for people with developmental disabilities, parent education, professional trainings, community events. We have a bilingual educator who does Spanish education and so much more. As far as where I learned about reproductive and sexual wellness, I did not take a human sexuality class until I got to college. So I did a lot of learning from peers and pop culture, which are two terrible places to learn this information.
Well, we'll have to hear more about that because I love your picture in the back. So we'll get into that a little bit later. Next up, we have Dr. Anna Marjo. Dr. AJ, how about we just do that?
Hi, I'm Dr. Anna Marjo. I'm a practicing urologist in Springfield since 2000. And as far as the answer to the question, probably school, I would think, on the poll.
Okay. Last but not least, bringing us home, Dr. Orr.
Hi, my name is Curtis Orr. I'm an OBGYN here in town at Mercy OBGYN and 2 half days a week at the Rocking Horse. I've been here since 2011. And as far as the poll question go, I would say my parents with a little bit of punitive action and the school.
Yeah.
You know, my education from my parents was much based on, you better not do this because of.
Right. I think I had a parent like that too. Yes. Yeah. Okay. Well, as you see, we've got some great experts here. Let's just dive in. Let's start at the beginning. Can we talk a little bit about preventative screenings and annual exams that we should be getting? What should we be doing?
Well, from our perspective in OBGYN, you should be getting your annual examinations on a yearly basis, whether you are in your teens or your post-hysterectomy or your postmenopausal. The screenings that go along with those examinations change by your age. Used to, when I started, we did pap smears on everybody every single year, from your first active intercourse until you couldn't come anymore. And that's changed now. We don't start our pap smears until you're 21. We do sexually transmitted disease screenings before that if you're sexually active. And we start adding routine HPV screenings in your 30s. Mammograms start when you're 40. And there's a little bit of leeway on whether you do it every other year or every year until you get in your 50s. And then it's definitely yearly. Osteoporosis screening with your bone density should start at 65 or sooner if you have risk factors. Colonoscopy should start when you're 50. If they're normal, they're every 10 years after that.
Does anyone else want to add to that or piggyback on that? Okay. So
I wouldn't mind piggybacking on that and just
okay.
Also the importance of making sure that as a woman that you're getting your breast exams, not only yearly, which would go with the pap smear. So when you go to get your pap smear, your doctor is going to do like the yearly breast exam, but also the importance of doing those breast exams daily when you're in the shower and reporting to your doctor if you find anything that's different. If you notice any changes in your breasts, on the skin, dimpling of the nipples or anything like that, discharge from the nipples, and the importance of that to make sure.
Yeah. So at the health department, what are some services that are offered through the sexual health clinic? Can you talk a little bit about that?
Absolutely. So at the health department, I think when people think about the health department, traditionally we're STD and STD treatment, sexually transmitted disease. Like we test your partners and we can treat you. And I think that's a lot of what people like kind of recognize us for. And that's what we've done for years and decades. But here recently, in about the past like 3 to 5 years, we've added lots of services, which I'm really excited about. We still do our STD testing and treatment partner services. We do pelvic exams, pap smears, breast exams, testicular exams for men. We do HIV testing and counseling. We also have on-site birth control services now. So we carry just about any type of birth control on site. So if you come to the health department and you want birth control, like you will 99.9% walk out with it that day. So you come to us, you tell us you want birth control, you got it. We carry the pill, IUDs, implant. We do pregnancy testing. We have emergency contraceptive services if that's something you need. Counsel and natural family planning. And of course, we have condoms for free.
Right. So a quick question just to piggyback on that. And I know we've got a question in the chat, so I'll get to that. But if I'm 15, I can come to the health department.
Absolutely.
Okay.
Yes. Through our program, we have the Reproductive Health and Wellness Grant, which is Title 10. It's a federal program which allows us to see minors without parental consent. We always encourage, though, when we have a minor that comes into the clinic, we want them to involve their parents and involve their family members. So be it a parent, a guardian, aunt, uncle, trusted adult, we always encourage that because typically our minors will have better health outcomes when they have a support system.
Right.
But absolutely, yes. If we have a minor that comes in, we will see them. We treat them like any other patient. HIPAA, parents can't call and ask. We can't confirm nor deny if your child was with us.
Right. Danielle, do you see some of that, in your role, in your profession with teens and teaching?
At the hospital?
Yes.
So right now, obviously, we're offering childbirth education classes for anyone that signs up. I have had some teens come, and sometimes they bring their support as like a parent. And I have offered it to bring more than one support person in class. And I did have somebody that brought like the dad and their mom, which is helpful because obviously they're going to help with the care of their infant. I also am starting to go into the schools right now and meet with the pregnant teens if they are okay with, and they're already meeting with the grads program. Jenny Harrell from the ESC goes in and meets with our pregnant teens if they consent to them coming in to give them services, and she meets with them on a weekly basis if they're at school. And I have started to go into some of those meetings and give them some education on what to expect when they go into labor, what to expect in the childbirth, coming to the childbirth center, trying to get them up there for a tour, giving them, the hospital bought a book just for teens that is very much on the level that they need to start off with. So we don't scare them too much about childbirth, but we also are giving them the information that they need going into the birthing process. Yeah. Plus, I think the best part about it has been that it's like a friendly face when they get there, because obviously I tell them I work on the floor. I could be your nurse. I can tell them what to expect and what care we give so that they're not so scared, because it is a scary process coming in.
Right. Okay. Let me jump to the question. The question is, if there's a history of breast cancer, should you start your exams yearly, and at what age?
Can you repeat the question?
Yes. If there is a history of breast cancer, should you start your exams yearly, and at what age? So probably flip it. At what age, if there's a history of breast cancer, should you start getting your exams?
So if there is a family history of breast cancer with a first degree relative, meaning a mom or a sister, it's never wrong to get your first baseline mammogram at 35. And I would start yearly at 40. Okay. I don't know that I would change the screening recommendations, and I don't think there's anything out there that says to change the screening recommendations if it's beyond a first degree relative.
Okay.
So, we get a lot of people that come in and say, my great grandmother or my aunt, or I got a cousin. And really, when you get that far out, it affects your family history, but it doesn't affect your breast cancer rate nearly as much.
Right. Okay. Thank you. Danielle, this question is for you. Danielle, does your organization partner with organizations such as Planned Parenthood that offer comprehensive sex education to teens that can help foster discussions about preventing teen pregnancy versus being a teen mom? And if not, do you refer out to agencies like Planned Parenthood or the health department for birth control?
So obviously I work for Mercy Health, which is a Catholic organization. I can obviously only speak on certain things when I'm with teens because of where I'm coming from. I do obviously talk about with them what their process is, because in our book it does go through, what is your future, like what are your future plans, like how are you, because I'm only meeting with the people that are already pregnant. So I tell them by the time, anything that I would tell them, even when they have a baby, that before they leave, they need to make sure that they talk to their physician about what they're going to do, to prevent this from happening going forward. So that's kind of where we kind of go with that. Obviously, Jenny Harrell, who is with the ESC, I think she does kind of touch on that a little bit more. My role is more just coming in to talk about the birthing process and to help them, educate them on that process when they come in and what to expect.
Okay. Sarah, do you want to add anything to that?
I think similar to what Danielle was saying, there are limitations based on the organization that is providing that service. So, if we are working within their schools or another community organization that they are a part of, we would be glad to provide relationship and sexual health education on maybe preventing future pregnancies.
Mm-hmm. That's good. I commented about your picture in the background that talks about sex ed saves lives. Can you talk a little bit about that?
Yeah, I would love to. So sex ed, when it's done right, supports health and safety. It's about empowerment of young people. Well, people across the lifespan, really. Just because we're adults doesn't mean sex ed has to stop. And I've trained plenty of parents and professionals who don't have baseline knowledge, let alone the knowledge needed to really support young people. So it's about empowering people with the knowledge and the skills that they need to make healthy and safe and informed decisions about their relationships and their sexuality and their sexual health for themselves and for their partners, as well as how to become advocates for themselves, like teaching them how to go to a gynecology appointment with Dr. Orr and ask all the questions that they want to ask, how to communicate with their partners. So it can truly be life-changing. And to the poll question number 2, where it said 22% of people answered other, I was curious if their answer was 22% was other because I didn't learn it at all. Because we know the statistics around relationship and sexual health education and how often it's not happening or not happening in the correct or in a way that is comprehensive. So sex ed, if done right, can truly have an impact on young people and people of all ages, really.
Do we, so I guess we talked about, where did you learn it? Where were you first introduced to sexual health and just getting that information? Is there a certain age, the right age for kids to learn about, making those good decisions, sexual health?
Yeah, this is a great question. And it's also very much values-based. We know, like, we can just name right now that there's a spectrum of beliefs about the types of sex ed that should be taught, about the messaging, and about the ages at which it should happen. So the answer for me is early and often. there are age congruent, age relevant ways to discuss all topics. So for example, obviously, when we're talking to a second grader, we're not talking to them about sexual consent, but what we can talk about is you need to get someone's permission before you give them a hug. You need to ask someone before you borrow their pencil. How does consent, the concept of consent, apply to their second grade brains and their second grade experiences? And similar to that, you can ask your family members not to hug them unless you get their permission. So we are instilling those messages about body autonomy and choice and consent in a way that makes sense to them at that point in their lives. And then obviously, as they're getting older, we start incorporating experiences and examples that make more sense for their development, romantic relationships, and then eventually sexual consent. So there are age congruent and relevant ways to teach everything. We just have to understand what those ways are. And there are tons of resources out there, and I'm going to share them with Joan to go out to participants, but authors like Roby Harris, who write books like It's Perfectly Normal and It's So Amazing and It's Not the Stork, which are medically accurate ways to talk to young people about things like pregnancy and birth. I gave my sister all of those books when I found out she was pregnant. And by the time my niece was 3, she had flipped through all of them. And she knows some of these things that many kids don't know. There's also a book called Sex Positive Talks to Have with Kids by Melissa Carnegie. That's a fantastic resource. So there's no right age. It's based on values, but early and often is the best approach because you want to talk to them about it before they have these experiences, before they get into relationships and even friendships, so that they're equipped with what they need to know and the skills that they need to do so in a healthy and safe way.
Okay, great. Thank you. There's another question that focuses more on men. What screenings are important for men and the timing of them? I think that's you, Dr. H.A.
Yeah, certainly. I mean, routine physicals from their physicians are probably where you start. As far as prostate screening, that's a matter of debate, honestly. It's not as consistent as it used to be, but certainly the primary care doctor would do at some point in their early 50s, probably a prostate exam. PSA screenings would, that's also debatable, but probably a one-time one in their mid-50s if there's no history. And then based on those findings, you'd have a referral over to us.
Okay. There's another question that is asking, what is the latest treatment for prostate cancer?
That's a difficult and complicated question. Prostate cancer is a broad spectrum of disease. It can go from very low grade to very high grade and aggressive. So knowing that first would determine what would be the right kind of treatment options. For a vast majority of patients that we diagnose with prostate cancer these days, especially it tends to be of a low risk or very low risk disease, we do surveillance. And probably 6 out of 10 men can have surveillance. Those, and beyond those, that group that isn't in the surveillance group, the options are ever developing between radiation, surgery, and then there are more focal therapies that are really new and developing.
Mm-hmm. So when you say surveillance, obviously I know that means monitoring. Is there a specific time frame? Is it monthly?
Certainly.
Is it, yeah.
Usually it involves routine visits to the urologist at the 6-month intervals.
Mm-hmm.
Usually after the diagnosis is made by a biopsy, a confirmation biopsy is done within the first year. And then follow-ups from there. Usually it's evolving, but roughly every 2 years, rebiopsying, doing MRIs to follow it. Basically, we know that low-grade prostate cancer grows very slowly, and for the vast majority of men will not affect their overall health. And so we can carefully but comfortably watch them over time and see if it changes.
Okay.
Hey, Nettie, can I interrupt just for a second?
Yes.
I think I'd love to see us put that next poll questions up. Take a bit of a break and take a look at these next poll questions. So Alex, behind the curtain, if you would do that, awesome.
Okay.
So, folks, take a look at this and take a minute and answer these 2 questions to the best of your ability.
I think one is a trick question to me. All right, let's take a couple more seconds and let's see. what the
And
results
then we
are.
have, yeah, and we do have some other fantastic questions in our Q&A box. And so I
Okay.
know we'll get back to those. So
Yes, we
keep
will.
those coming, everybody.
Yes, thank you.
Mhm.
Okay. In general, 75% said puberty started at age 12. Okay, so I'm just going to be transparent. That's when it started for me. I'm not sure about others, but it was 12 for me. Question 2. How comfortable are you bringing up sexual reproductive concerns with your medical provider? 79% very comfortable, which is good. I think that's great. That shows that you've got a really good relationship with your provider. Is there a specific answer for number 1, Joan? Is that right? Or is it just—
No, I'm going to defer to the professionals on this call. I've heard different things, and I would just like to know whether Dr. Orr or maybe Sarah, Danielle, Brittany, maybe you have more updated information. I've just heard quite a lot from teachers and school nurses. So you tell us what's true.
Again, there's a spectrum there. 12 used to be the right answer. But the age of menopause has continued to get younger, or not menopause, but puberty, sorry, has continued to get younger and younger and younger over time. So it's not unusual to see somebody late in their 9 or 10 or 11 be certainly dealing with puberty issues.
Brittany, you were going to say something.
I was going to say what Dr. Orr said was that typically we usually will see girls a little bit younger than 12. I think the average age for us usually is around maybe like 10, 11. Up to 12 boys. I think the general consensus is like sometimes they're usually a little bit behind the girls by maybe a year or so, but no, Dr. Orr covered that. Perfect. Thanks.
Okay. Okay, well, there are a few more questions in the chat, so let me ask this. What sex education programs are offered to kids and adults with developmental disabilities? That's a great question.
Yeah, that's a program I'm really proud of. We started that back in 2017, and we work with people of various ages with various developmental disabilities. Mild cognitive. I've had a client with fetal alcohol syndrome, Prader-Willi, autism, Down syndrome, all types of disabilities. And we just provide one-on-one or group sessions, and the lessons are really tailored to their needs. So we develop lesson plans based on their cognitive age, not their chronological age. So if they're 25, but because of their disability, they cognitively are teenagers, we will plan a lesson meant for someone that is a teenager and not someone who is 25 years old. So it's separate from the programming that we offer in schools and to parents and professionals. It's really tailored to the needs of, like I said, that individual or that group. And it's similar topics, relationships, consent, communication, boundaries, internet safety, a lot of things that can create challenges in the community of people with IDD are the areas that we tend to focus on.
And the last question, can caregivers, I'd like to hear from everyone with this. This is interesting. I'm sure parents and others may want to hear. Can caregivers make their teens be on birth control? The example is if their teen is having sex and they're not being safe.
I know in our practice that and we have had parents actually come in saying that they absolutely want their child on birth control like today. And essentially we treat everybody that comes in like they're our patient. So if our patient tells us they absolutely do not want birth control, like we will not forcibly put it in. No.
I would second that from our practice. If they come in, I mean, we'll have a big talk. But if at the end of that discussion, the patient says, no, I'm not going to do it. And the mom says, yes, you are. You know, I kind of tell them to go back, regroup at home, you know, have a conversation between the two of you, and then come back and we'll sit down and talk about it again.
So if we have a teen that chooses, obviously, not to protect themselves, obviously they put themselves at risk for STDs. Can we talk a little bit about that? I've been hearing, I work at Rocking Horse. I've been hearing that there's been an increase of STDs in our community. Can we talk a little bit about, the STDs and then the risk?
Yeah. I could talk a little bit on that. So yeah, there has been an increase in STDs in our community. So I'm trying to think of how I want to word this. So when you look at the numbers from year to year, sometimes it takes a few years to kind of see a trend. So as of right now, like chlamydia and gonorrhea rates are still kind of high in our community, but they are looking like they're starting to trend down, but we still need a few years to kind of like see if that trend is going to keep going.
Mhm.
Unfortunately, though, our HIV and syphilis rates in the community are rising. Right now, Clark County is in a syphilis outbreak. If you're from the area, you probably have seen the billboards up all around Clark County, big orange ones, that are pretty much just letting everybody know, like, hey, COVID's going on, but like there's still an outbreak and other diseases going on in the community. So right now we have like some preliminary numbers that I don't really kind of want to throw out there. But if somebody wants those numbers, they can reach out to us in offline and we can talk about those.
I would agree with that 100%. And I found that question interesting when I looked at the list of questions. So I went to the Clark County Health Department website, and most of that data is right there. They've got nice graphs between 2016 and 2020. And I completely agree with what you're saying. Chlamydia is kind of up and down. Gonorrhea is going up a little bit. But, the one that was remarkable to me was syphilis. That between 2019 and 2020, there was a 100% increase in the rates of cases of syphilis in Clark County.
And I would say too, Nettie, sexual health education is a huge preventive tool there.
That's
if
right.
people don't understand how these STIs are spread and how they're prevented, then they're not equipped to be able to do that. So yes, most people understand that STIs can be prevented with using external condoms that go on a penis, but are they also aware that most can be spread through oral sex?
Right.
Some can be spread through anal sex. So understanding again, the whole view of these STIs, including transmission, prevention, treatment, and if they're curable, which comes from comprehensive sex education.
Yeah.
Or talking to your provider.
Absolutely. We see a lot of clients that come into the health and wellness clinic, and depending on their age, some people don't even know what syphilis is. Like they have no clue. And then if they do know what it is, they're like, well, that hasn't been around for decades. Well, it's back.
Right.
We're doing a lot of education with clients and doing outreaches. And the health department is doing a campaign and trying to reach people to get them in and get tested, and kind of taking the stance when the HIV campaigns were out, like, know your status, like just it's a simple test. Just know it's not a routine test unless you ask for it. So.
Okay, that's a good point. Dr. AJ, you unmuted yourself. Did you want to say something?
No, sorry.
Okay, well, hold on, because I've got a question for you and Dr. Orr. Okay, this is for the doctors. In today's society where laws are being passed in states such as Florida's Don't Say Gay law, how do you encourage inclusion in your practice and among your patients? Do you see transgender patients?
In my practice, we see some transgender patients, and my viewpoint is kind of a general one, that 5 millimeters below our skin, we're all quite the same, and we should just treat each other that way. So that's our practice motto. We don't worry about. We see things that run the gamut of health issues, and we just take care of them as they come.
I would say we see a fair amount also, maybe not as much transgender as we do same-sex couples. We do a lot of same-sex couple deliveries. And I'd say the same thing, you walk in the door, you're a patient, no matter what.
That's a good point. That's a good point. Sarah, for everyone, can you share again where you work?
Absolutely. I'm the Director of Education at Planned Parenthood Southwest Ohio.
Thank
So
you.
we have 4 health centers. We do have one in Springfield on Bechtel Avenue. We have one in Dayton, one in Hamilton, and one in Cincinnati.
So if I could just transition just a bit, because obviously each of you are in vehicles where you may see someone that comes in that has a problem, and maybe they don't know about that. How do you help them navigate the problem? Okay, so let's say they haven't gone to the preventative care and now there's an issue. How do you in your respective vehicles work that patient through and help them get the services that they need?
For our practice, and I'll be honest with you, it's way easier to get that done when we're at the rocking horse. The 2.5 days that I'm there, because the services are right there. I mean, they're right there in front of you. All you got to do is say, I've got this lady and she's got a substance abuse problem, or I've got this lady and she's got housing issues, or she can't get the help that she needs. And it's all right there under that roof. So it's way easier at the rocking horse than it is in our practice. At our practice, it's a little bit more hunting and calling and trying to find the right people.
I would agree. It is challenging when you don't have all those services directly, within arm's reach.
Mm-hmm.
We do a lot. At our clinic, we do a lot of self handoffs. So if we see people that are in need of services that we don't provide, we will usually reach out to the person or doctor or housing or whatever it be that person needs directly, and try to kind of follow through and hold their hand, let them know what they need to do and equip them before they leave their appointment.
And to add to that, a long time ago, there was a resource here in Clark County, and I'm not sure if it's still available, but for the private offices it was like a binder of all the services that were available and the contact people and where and how you could do what. I've not seen that for a long time.
It's here. We have it. Actually, the Community Health Foundation puts that out every single year. Bam, there it is. You ask and we give it to you. So Dr. Orr, I'm not sure if you're coming to Rocking Horse this week, but I will definitely make sure. Thanks, Joy.
Thank you.
Yes, there it is right there.
There's actually a whole case of them in the birthing center, Dr. Orr, so I will get you one.
Yes.
But I will also say that going along with that slide that I sent you, Joan, I don't know if Alex can show that, but there is a new app that the hospital has supported. It's called Yomingo. It's actually for pregnant women, but a part of it we built for Springfield. And there is a tab on there that we have added that says Springfield and Urbana resources. I've kind of drawn a lot of it. There's an organization in town that I am a part of. It's called Start Strong. And we're building a website that will kind of bring all of those things into one website. Like kind of, you could go there and find all the resources you need for, prenatal care, to postpartum care, to caring for your newborn and your children. So we're building that, but there is on this app, if you go to the QR code and you scan it, if you're pregnant, this also entails like a contraction timer and lots of education for prenatal care, newborn care, and labor and delivery education. So this is a great tool for anybody that's pregnant or a new parent, because it does have areas where you can put in your baby's measurements, immunizations that they get from the provider. And it does obviously have a tab based on our childbirth education classes if you were looking for how to enroll in those. So this is kind of a great tool to go towards for that. And it does have a list of the resources in the community, which Start Strong is trying to add to also.
That's great. Thank you. So we have two questions in the chat. I'll read the first one. Any tips on establishing better communication with your partner and with your children?
About anything in particular or sex?
I
Relationship?
would assume so, because we're talking about sex, baby.
Brittany, I'm sorry, I think I cut you off. Do you want to go ahead?
I was just going to say, when talking with your partners and talking with like your children, I think one of the best things to do, and what I do when I go out and I do teaching, is I kind of see what they know. So like, instead of saying, we're going to talk about X, Y, and Z, I kind of formulate it like, so tell me what you know about X, Y, and Z. And then you can kind of see like where they're at and where, there might be some deficits, and then kind of start from there.
Mm-hmm. Yeah, I think talking with your kids, one of the things that we always teach parents about is teachable moments. So we've all had that like horrifying experience where your parent like comes into your room out of nowhere and sits down on your bed and it's like, so periods. And you're like, what, where did that come from? Why are you doing this to me? I would rather like shove my head under a pillow and not talk about this, but find ways that come up more naturally to have the conversations. If something happens on a TV show, maybe there's a sex scene and you didn't see consent talked about, or anything negotiated, or condom use wasn't discussed, bring it up there. So like, I didn't really see them talk about protection. Did you? What do you think about that? If you hear a lyric in a song or something, use the things that are already happening around us instead of that awkward, like cold call approach. One thing that one of my coworkers does, her name is Stephanie, guarantee she's on the call, she's fantastic, is what she calls car talks. So she has 2 teenage girls and she has conversations that when they happen in the car, they stay in the car. And it's where they can have some of their more like sensitive conversations. And another thing there is like, you're all facing forward. You don't have to look at each other. So there's a lot of ways to just use what's already happening in the world around you to start those conversations and to open that line of communication, instead of the really awkward experience that we've all had of just them like kind of blindsiding you. Mm-hmm. And then the car talks are another great way to start conversations with young people.
That's great. TED Talks who? I like car talks. It sounds great. Really good. One follow-up question is, what is the difference between comprehensive sex ed and other approaches?
Yep, fabulous question. So there are a few different types of sex education, comprehensive sex ed, and then the other ones typically fall under abstinence only, also called sexual risk avoidance. It was rebranded with the last administration. So abstinence only and sexual risk avoidance typically teaches that abstinence is the expected standard of behavior for teens, but it typically excludes any information about the effectiveness of contraception or condoms, how to use them, how to prevent unintended pregnancies. It also excludes information about healthy relationships, consent, sexual identity, some of those topics. And research also shows that abstinence-only education is ineffective. It does not have positive outcomes. It can be harmful to young people, while comprehensive sex education is all about, like I mentioned before, empowerment, this healthy decision-making, choice, autonomy, building knowledge and skills and attitudes that they need to make healthy and safe and informed and empowered decisions. In those programs, you see a lot about relationships, skill building around communication and consent. We're also talking social media, internet safety, protection methods, pregnancy and birth, reducing the risk of STIs. So the conversations are broader, they're more inclusive. And then again, we are also saying things like abstinence is the best choice for young people. It is the only 100% way to prevent unplanned pregnancies and STIs. However, if and when you make that choice, here is what you need to do so safely and in an empowered way. As far as what's taught in Ohio, so those are the 2 different types, and you'll see various things taught, and in some schools there's nothing taught. So Ohio is the last state without health education standards. We are a home rule state, which means each district gets to decide what they teach. So because of this, you see wild inconsistencies, not only in Southwest Ohio, the service region that I work in, but across the state. So to answer your original question, there are typically about 2 different kinds, and again, heavily based on values and where you're at in the state as to what will be taught.
Great, thank you. We have another question. Where in Springfield can a man on Medicaid receive a vasectomy?
That's a good question. I think we do vasectomies in our office, and I'm not aware that the vasectomies can be done there. I don't think Medicaid has a preclusion to it. But I would have to double check.
Okay. Dr. AJ, is that really the only reason why people come to see a urologist? What are some other reasons why people would come to see a urologist?
In terms of our discussion today, we see folks for multiple things. It can be for infertility. If they're trying to have children, they can't. That's one scope of it. It can be those who are seeking for sterilization, of course. It can be for those having some, sexual dysfunction, whether it's erectile dysfunction or things like premature ejaculation. It can also be for, things that they notice on their skin in the scrotal and genital area, and they're not sure of, and they're not comfortable having their primary care look at it, or their primary care doctor isn't sure what it is. That's what we see folks for. Beyond that, obviously, urology means we take care of urinary issues, and from the gamut of cancer related to kidney stones to incontinence.
Mm-hmm. Okay. How do we begin? You had, brought up a touchy subject, erectile dysfunction. How do we begin to have those conversations that are difficult to have? How do we do that?
It starts really, to one, destigmatize it. It's extremely normal. Up to 10% of their men in their 30s have trouble with erections, and that grows every year by about 10%. So if you look at a 60-year-old, it could be, 30% of those may have some erectile dysfunction issues. So to state that it is not unusual nor uncommon is the first thing. Second is really to do an assessment of what it is and have an open discussion of it. A lot of times, you're right, with not very good sexual education, men have a trouble even explaining what's happening. And so sometimes we have to break it down by saying, okay, this is the process. Okay, what happens at this part of the process, and what's going on here? Mm-hmm. And we have a sexual health inventory that assessment that we have every patient fill out, when they come in. And they do it privately, obviously, before we walk in, and we take a look at it, as even if they're seeing us for a completely different issue,
right?
Because that's really the only way to bring it up is to have people start thinking about it actively.
Mm-hmm. Are men more comfortable doing it that way? Are you able to get?
Yeah. I think as that seems to be the most effective way. Asking directly, and especially, gender roles. If you have a female nurse asking questions about erectile dysfunction, you won't really get many men agreeing to having any issues.
Right.
So,
on anything.
On anything, exactly. Everything's fine. So, but by filling out that inventory, that gives us an opportunity to look at it, at some point during their visit.
Okay, thank you. We have another question did someone else want to comment on that? Okay. We have another question that was asked by the audience. Why are preterm births so prevalent in our community?
I think a lot of that is based on our population. We have a fairly high rate of sexually transmitted diseases. We have a fairly high rate of people who don't necessarily take the best care of themselves. We have a lot of obesity. We have a lot of hypertension. There's vaginal infections that put you at risk for preterm rupture of membranes, or where your water breaks early and puts you at super high risk for having a preterm delivery. And it's growing daily. We have a huge population of people who choose not to access any health care until they're 34 weeks. And they may show up for a visit or two, and that's it. And there's no screening and no monitoring and no hope for intervention.
I did not know that. Man,
This is actually why we have started doing more of the education out in the community, like in going into the schools, because we actually have an organization that we're putting together at the hospital. We've been meeting, like a collaboration between the health department and people in the hospital, the physicians, and we're trying to discuss some of those things that are happening. And preterm birth was actually one of the things that we discussed at our last meeting, and talking about how we can get people to go to their prenatal appointments, because a lot of the time we are seeing people that aren't. Sorry, my dog is.
You know, and a lot of it now is becoming more and more, and I know you see it at the Rocking Horse every single day. A language barrier is huge. You know,
huge.
we have interpretation lines, but you're never sure what they're really getting told and what they're understanding.
Right.
And they have difficulty getting to appointments. And a lot of the reason that they come or not, they don't come is cultural, you know?
Yes, that's a good point. That is so true. Yeah. There's another question related to that. What are some reasons for the difficulty of getting pregnant for men and women, and what medical intervention can be done to assist?
Yeah, infertility is obviously multifactorial. We talk about this, that it can be both the man and the woman. And so if someone presents to us that way, we always try to make sure that both are being evaluated for it. I guess to answer your question, what are the causes for this? That's a really difficult one. Same things that Dr. Orr was mentioning, hypertension, obesity, general poor health can affect sperm counts. Prior injury, trauma, et cetera, can reduce sperm counts. So it's one that you really can only do by evaluating them thoroughly.
Yeah, I would agree with all that. I tell the patients when they come into the office, I mean, if you really want to boil it down to the simplest terms, you got to have an egg, you got to have sperm, and you got to have a way for them to get together. And not just talking intercourse, but there can be cervical mucus problems. There can be barrier problems within the uterus. They can have tubal factor infertility, meaning have they had PID or endometriosis, PID, pelvic inflammatory disease, or endometriosis that scar the tubes so they can't get together. Are they ovulating? Are they not ovulating? So it's, as Dr. AJ was saying, it's a multi-step process to figure that out.
Great answers. Thank you. Another question, switch gears a little bit. How should we encourage males to get routine exams and testing outside of STI? What language should we use with our loved ones, including spouses, family members, and male friends or bodies with a penis?
I think the best answer would be most things are preventable, with early screening and regular exams. That a disease process, simple things like erectile function can be a window into heart disease. It can be a window into diabetes. There are many other disease factors that cause erection problems. So if someone is having those kind of issues, it makes sense to get checked out, because it can be an early sign of other problems.
Mm-hmm. Anyone else want to add to that? Okay. We're winding up, but I've got one more question. And it reads, is sexual education focusing on safety, consent, healthy choices offered to incarcerated people? It is, I'm
sorry, I cut you off. Go ahead.
That's okay. Yeah, it is unusual for this population to have issues with unhealthy relationships, which may lead to bad choices and then incarceration.
Yes, exactly. I feel like at one point, Brittany, the health department was doing this, and you can certainly chat about that. Pre-COVID at Planned Parenthood, we were building a program specifically for incarcerated women. However, global pandemic, not able to get into incarceration facilities to deliver the program. And unfortunately, at this point, it still hasn't gotten off the ground. But Brittany, like I said, I think the health department was doing this at one point.
So, so the health department does go into the Clark County Jail every Tuesday and offer sexual health and wellness services to the men and women. So that includes everything that we do in the program, including birth control, if they want birth control while they're in there. There's a couple little factors there, a little caveat, depending on what type of birth control they want, but especially if they're getting ready to be released, if they want IUDs or if they want Nexplanon, of course, we encourage that. STD testing, we do patient teaching and everything. And if we have someone in that says, hey, when I'm released, I want to have children, we start that talk about healthy pregnancies and what they need to do. So we do education at the jail.
Great. Well, I think that 1 hour, or actually 57 minutes, goes pretty quick. But we've got one more poll question that we want to pull up and give everybody the opportunity to answer that. And then I'll pass it back to Joan. That's poll 3. I think we've got that's poll 2. We need poll 3. Oh, no, that is poll 2, I guess. I apologize. Yep.
That's fine. I think it's just mislabeled. So yes. So we'd like to know what you've heard, if you've if you have any responses to what you've heard today, and whether you intend to come to another Break for Health session, because we would certainly love to have you. Alex, would you mind pulling up the slide with the panelist contact information? If we could take a look at that while the poll is still up. And I just want to thank all of you for spending some time with us, for sharing your knowledge and your experiences for this lovely lunch hour conversation. Probably unlike not like some that I usually would have with my friends, but absolutely fantastic. Great information shared. I appreciate you taking the wonderful questions that our attendees submitted. I think we've all learned a lot. This slide gives you contact information so that if you're wanting to follow up with any of our speakers, this is how you can reach them. And maybe let's go ahead and pull up we don't need to pull up the responses to this poll, because we just want to know that you have learned something new and that you plan to talk to somebody in your life about how to stay healthy with reproductive and sexual wellness throughout the entire lifespan. So what I'd like to do then is just share our community resources. As you can see, we haven't updated the cover of our health resource guide yet, but the new one is the 7th edition, and it is currently being sent out to organizations in the community, and they're available at Community Health Foundation for anybody who would like to pick up one or several. And there's our information to contact us. And anytime somebody's facing an emergency or has a question that they don't know how to deal with, 211 is also a fantastic resource in our community, and that's sponsored by United Way. I also want you to know that we are planning, and some folks in this crowd might be interested, that our next session is going to be to talk about men's health. And so part of that probably will be to talk about how do we convince men that their health is important, not just to them, but to the people that love them. And so that discussion, that conversation will take place on June 8th. And I look forward to seeing many of you, both attendees and perhaps some of our presenters, our panelists, to join us for that session as well. You will receive a survey at the conclusion of this session. It will also be emailed to you following, and I sure hope that you'll take a moment to respond to that survey and also provide your suggestions for future Break for Health sessions. We certainly take those seriously and try to work them in. Nettie, is there any final words? Any final words from you?
We've talked about sex. And I've
We
gotten,
have.
we have, and it's just some valuable information. And we're fortunate to have such great experts. So stay safe.
Absolutely. Have a fantastic afternoon, everybody. Thanks so much for joining us, and I hope to see you again in June. Have a good afternoon.